Welcome, everybody. It is an enormous pleasure to have you all connected from all different parts of the world to this first webinar of the ENDE group, the European Network of Dental Education. I am Isabella Rocchetta, and I have the honor tonight to present what ENDE is and the initiatives that we have together with the other board members and the organization have planned for the near future. So if I may share a very short presentation. Let me just check that everything is working well. Everybody, I think, should...
Yes, everything's fine.
Fantastic. So in order for me to present, I wanted to introduce you and to make you understand what ENDE really is. ENDE is a group of highly qualified colleagues all around the world who have one main aim or focus in their mind, which we believe is the thinking or organization of a correct treatment planning for all our patients in an interdisciplinary approach. We say this because we think there is a lack in our field. We have a lot of webinars or organizations, associations, mainly focused perhaps on one special discipline, whereas we are a group who have completely different backgrounds, and this today is the example. I would like to suggest to mark your calendars for the next free webinar, which will be very similar to what we are doing tonight. So tonight is our very first one. The next free webinar, which will happen on June the 4th at the same exact time from 7 to 8:30 p.m. will be a completely different, obviously, case from today. And we will have a different presenter than today. We have Dr. Pelekanos, and the moderator will always be Professor Bichacho, who you will see tonight. We have, again, a very diverse yet extremely sophisticated panel, ranging from prosthodontist to the periodontist, ortho, endo, restorative, and dental technician, because we truly believe that this is the base to be able to better treat our patients, which is the aim of our group, of the ENDE group. And I strongly suggest you go and look out at the website and register, because you will receive newsletter, you will receive information, and the exciting news that we have in our sleeve. Now, I would also like to present the very first face-to-face meeting that we call Module 1. This is a proper, I would say, very exciting 5 days divided into two different weekends. You will see at the bottom of the slide the dates. We're talking about October 2025, and the second date will be in January 2026. It will be held in a beautiful place. I've never been there, but apparently it's stunning, in Denmark. And so it is a very attractive location. And we are a group, as you may notice from the names. I will not read them, not to bore you, but we are all from completely different backgrounds, and we will basically convey the important message of the correct roadmap or formulation of the treatment plan. We know that the success of a procedure is everything that is the thinking process at the very beginning. And this thinking process requires different specialities, different backgrounds. And to us, this is probably the most important message that ENDE wants to give out. And again, our aim is to treat better people. Now, if I go into the details of this module, we have basically 2 weekends, one composed of 3 days and one composed of 2 days. And the weekend one, which is the upcoming one in 2025, which will be the 3 long days, we will go through really what is necessary in a very schematic and didactic way, from data collection to obviously how to formulate the correct diagnosis and hence the prognosis, various hypotheses, because we have to be realistic with our patients. It depends who we have in front of us, and this will differ our approach that we have with them, and of course various then options in terms of also how to sequence the treatment plan. What goes first? Do we always follow the same pathway? Does it change according to which patient, which case? So this is, it will really dig into every single detail. And last but not least, we will have a group discussion, which will be very similar to what we're doing tonight. However, obviously being in person, it will probably be with many more details. And we will show cases and also demonstrate how cases should be presented. Which format, which are the parameters that we should mention. And the following appointment, which happens to be in 2026, then it will be the same idea of a case presentation, but this time created by the delegates. So we want to give the possibility to the delegates who have listened to the first weekend to expose and present their own cases in groups, in order for it not to become too, daunting and hard to prepare. So there will also be a lot of teamwork, a lot of networking, and we are creating, I would say, a very large family. So we have hopefully created something very different and very unique. We're very proud of the ENDE group, and I hope tonight you will be enjoying very, very much. Just a little sneak peek of what would happen in the future. The module 1, by the way, will be repeated in different countries with different teams. So the idea is to spread the word. We are obviously starting with 1, and then according to the interest, we will then repeat this throughout Europe. And after the successful module 1, we will get into the possibility to then dig into different modules. Here you see them listed with different ideas of, again, there will be, the basis is the interdisciplinary treatment plan for every single module. So how to really treat our patients 360 degrees. With this, and I will pass on the ball to Dr. Stefano Gracis, who will present the case today, and Professor Nitzan Bicaccio will be our moderator. I would like to remind everybody listening that none of us have seen the case, not even myself, who has the privilege to work in the same practice as Stefano. So I'm quietly in my home, and I'd like to underline this because I have never seen the case. And the same thing will happen during the other webinars and the modules. Everything is very spontaneous because it has to be the famous Monday morning, a complex patient. We have to put our heads down and try to solve the case. Thank you very much.
Well, good evening, everybody in Europe. Good night, everybody in Asia. Good day in America and South America. We are very excited to start this endeavor of our treatment planning seminars. I would like just very shortly to present our panelists. You just heard Isabella. Isabella is a top world periodontist, and she's practicing mainly in Milan, but also in London from time to time. Then we have Christine from Iceland, and Christine Hemmilsdottir will be our orthodontic expert for the case. Then we go to Italy, back to Siena, and we will have Simone Grandini as a restorative and a dentist and an endodontist. Then we go back a little bit north to Malmo and Oslo, where Per von Stern will be our prostodontist expert. And then we go south again to Geneva, where Vince Fermer will be our expert dental technologist. You can, if you don't know those people until now, you will read about their CV at your free time, but I can assure you that all of them are top clinicians, researchers, and I believe that together with their collaborative minds, we will be able to come up with very interesting insights. Stefano Grachis, the presenter today, is a world-renowned prosthodontist. He is practicing in Milano, Italy. He had his uh, degree, master degree. He started with Penn University, where he got his first degree. Then he moved to Seattle under Ralph Eudelis when he became a certified board member. Prosthodontist is very much involved both in Europe and in America in the elite academies of restorative, prosthetic, and aesthetic dentistry. And he will try to share with us a prognostic-based, evidence-driven treatment plan. And this is very important for us to understand that whenever we are trying to come up with some solutions or some options, everything needs to be based both on our experience on the literature and what might be the best prognosis for the option chosen. Stefano, please.
Thank you very much, Nitzan. It's a real pleasure to be here and to be the one to kick off this initiative of ENDE's webinars. And as Isabella said, this is the first of a series of webinars we will be organizing. So without any further ado, let's go into the clinical case that I have prepared for you. Actually, it's a very young patient who came to my attention when she was only 16 years old. From a medical standpoint, she has no issues and no contraindications to dental treatment. The reason why she came to see me is this. 2 years prior to my initial examination, she was involved in an accident with a moped, and she hit her face and her teeth on the pavement. And this is what happened, as you will see here. You know, we have definitely a lot of issues, challenging issues, that will need to be addressed quickly. So, of course, she is concerned about the looks, about the aesthetics, the appearance. She doesn't feel comfortable going around with this type of situation. But at the same time, it's clear that it's a complex condition. You see she has a small scar in the lower lip, and that's a consequence of the accident. Lip mobility was slightly affected, but not that much. From an oral hygiene point of view, she does brush twice a day, and she uses a floss only occasionally. Looking at her extraorally, she has a very symmetrical, oval-shaped face. Both TMJs are within normal limits. There are no clicks, no pain, nor spontaneous, nor upon palpation. The mouth opening is again in the normal range, and she has no issues with her muscles because they are absolutely asymptomatic. Very bright kid, a very, nice person, but again, she has a complex because of this smile. Now let's look inside the mouth, and you start really having a better picture of what is a current condition. So number 12, number 11, and number 21 were affected by the trauma. As a matter of fact, number 11 was avulsed and was then reimplanted into her mouth. And this tooth, as you will see later, is ankylosed. Number 12 and 21 broke off in the cervical area, and now they have 2 provisional restorations. So these are provisional crowns which have been attached temporarily to the roots, but she has been going around with them for 2 years now. She doesn't have many other issues, as you can see from these occlusal pictures. You see that all 3 teeth were endodontically treated. So even the tooth that was avulsed and reimplanted, the other tooth teeth were broken, but they did not get reimplanted. This is a closer view with the periapical radiographs. And posteriorly, as you can see, there are no issues with caries, interproximal caries. She still has the wisdom teeth, but eventually they will be removed. From a periodontal standpoint, we have an issue with the lateral incisor, number 12, which actually has a vertical fracture of the root, a crack line that goes up. So you can see a very deep probing in correspondence to the buccal surface. As I said before, number 11 is ankylosed. And there are some inflammation in the posterior. In the lower arch, really no issues whatsoever. She is a healthy kid. Here is a view of some cuts of the CBCT that was taken when she came to us. You can see that number 11 is really outside of the arch. That's where it was reimplanted, where it stabilized, and eventually where it ankylosed. There are clear signs of external root resorption on this right central incisor. Instead, as I said before, there is a fracture of the root of number 12. So this is a tooth with a hopeless prognosis. 21 has some structural compromise. You will see it better later, but it's not as bad in a shape as the other two teeth. We did look at her also from an orthodontic point of view. Orthodontics was actually taken into consideration for different reasons. So I had the orthodontist run an examination. The orthodontist I usually work with is David DeFranco, who has his own practice here in Milano. So he did a side film and he did the cephalogram tracing of Carolina, of this patient. And you can see here some of the numbers that, for those of you who have familiarity with orthodontics, will mean something. You can see that she has a tendency to a prognatic maxilla and a retrognatic mandible. She has a tendency to a class 2 relationship. Again, here, they are not far off, the values are not so far off from the norm values. She does have a fairly straight profile, but you will see in a while what really David and I look together to try to sort out the type of treatment that we think is most indicated for this patient. So here are some screenshots of the intraoral scans that we took. And here you see every time David and I look at a patient who may be a candidate for orthodontics, we look at these 6 variables: patient profile, skeletal pattern, the inclination of the incisors, degree of crowding, the canine relationship, and the midline alignment. So in this patient, in Carolina, this is the current situation. She has a flat profile with a normal divergent skeletal pattern. Looking at her, we can see that the upper incisors are slightly retro-inclined, while the mandibular incisors are normally inclined. There is very little crowding in this patient, almost none. The issue here is the fact that we have a class 1 relationship on the left side, but really a class 2 relationship on the right side. And ideally, I would like to end with a class 1 also on the right side. And as a consequence, we have a malalignment, misalignment of the midlines. So the upper maxillary midline is 1 millimeter to the left with respect to the facial midline, while the lower midline is 2 millimeters to the right with respect to the upper, to the facial midline. So the current situation should then suggest something to you, and I'm not reveal what these situations suggested to us. So this is for you to understand what are the implications of this current situation. But this is the exercise David and I go through every time to communicate better, for me to understand better the orthodontist, and for him to understand what my requirements from a prosthetic point of view are. I always run a functional analysis. So this patient has a repeatable maximum intercuspation position where all posterior teeth contact. There is a very slight discrepancy between centric occlusion and maximum intercuspation. It's about 1 millimeter. And the first contact with the condyles in centric relation are actually at the 1747 second molars on the right side level, okay? Then you can see here very clearly the class 2 relationship at the canine level on the right side and the class 1 on the left side. There is a discrepancy of the midlines, as I mentioned before. We have 4 millimeters of overjet. We have about 3 millimeters of overbite, which correspond to about 60% of the lower clinical crown covered by the upper teeth. There is a cross bite in the posterior at the second molar level on the right side and at the first and second molar level on the left side. So you see the full picture. In a right lateral movement, there is initially canine and premolar come into play, then only the canine. In the left lateral, there is a canine guidance, very efficient. In protrusive, she tends to hit only the teeth on the right side, the incisors, and eventually the lower canine on the right side. Okay, this is the list of diagnoses that I put together on the basis of the data that we collected. So there is a generalized gingivitis. There are 3 endodontically treated teeth. There is an ankylosed tooth in a buccal position, and this tooth has external root resorption. There is a tooth with a vertical crack line, number 12, some defective provisional crowns, 12 and 21. There is a definite asymmetry in the gingival scallop, a class 2 malocclusion with a bilateral posterior crossbite, the facial midline non-coincident with the upper and lower midlines, and unerupted wisdom teeth. So this is the list of the issues, of the pathologies, of the problems that we noted. From a prognostic point of view, my general prognosis, that is a prognosis that takes into account the compliance of the patient, the ability of the patient to understand what we need to do and to follow with the proper hygiene, I would say very good. She's motivated, she wants to solve her problems. From a tooth by tooth prognosis, well, there is no question that number 12 cannot be maintained, while there is definitely a big question mark on both 11, which is ankylosed in a buccal position and with some areas of root resorption, and 21, which has some structural issues, but maybe it can be maintained. We will see that. The aims of the treatment that we are fine-tuning and proposing to our patients are, of course, to eliminate any pathologies, gingival pathology in their case, replace the missing tooth, for sure, number 12, maybe also 21 and 11. We will discuss that. Improve aesthetics, that's her chief complaint, and possibly correct also the malocclusion. The one thing or the two things you need to keep in mind, however, is that patient is very young. She's only 16, so let's not forget that. And she has definitely a very high smile line, so anything we do for her will be shown to the entire world. So that's why it's such a challenging case. So Nitzan, this is the initial situation of this patient, and I give the word to you.
Okay, I would like first to ask Christine, when it comes to ortho, in such a case, do you think that it is imperative to fix the posterior crossbite and to bring the unilateral class 2 into class 1? And if yes, what would you do?
The posterior crossbite is not her biggest issue, but the problem is that she's class 2 on the right side, and she will probably need implants. And you have to decide now if you're going to correct the distal occlusion in order to place the implants in the right position. That's the difficulty in this case. And you might be able to correct the class 2 malocclusion with a carrier appliance. I use that a lot. You can use it only on one side. And then you would need fixed appliances probably in the lower. There are so many questions here that I think nobody can answer. Stefano, this is a very complicated case.
It is.
So you have to decide now if you want to correct the malocclusion or not. The first impression, sorry?
If the treatment team asks you, please give us your opinion of how to correct and what to correct, what would you suggest?
If we decide to correct the malocclusion, I would suggest a carrier appliance and fixed appliances, or at least the carrier appliance to correct the malocclusion, the distal occlusions on the right side. That would be, I think, the minimum if we decide to correct it. On the other hand, she's 16. This has not been corrected.
Mm-hmm.
So this has not been seen as a problem until now, right?
We don't know.
We don't know.
We really don't know. And we don't know if, for instance, the posterior crossbite has been bothering her or not. But from your professional point of view, would you leave it as is, or you would try to correct it as well?
If I want to make it perfect, I would correct it.
Okay.
But if it's the patient's concern that she would like to leave it, I don't see a posterior crossbite, like in this case, as a problem, because I don't think it's causing the midline shift. I think it's the distal occlusion which is causing the midline shift on the upper and the lower.
And how long would such a treatment last?
With a carrier appliance, it might, in a case like this, it would always take like 3 to 6 months minimum.
Okay.
Just to correct just to have her in a neutral occlusion on the right side.
And if it is a hollow treatment,
the whole treatment would be 1 to 2 years, I think, with fixed appliances. Yeah.
Okay. And what would you suggest to do with the front upper teeth that we already know that 2 of them are actually should be removed at a certain point of view?
Yeah. Yeah. This is the problem with the young age of the patient, because you want to keep the teeth as long as possible. The first thing I would do is to talk to an expert. I would talk to the other specialists that work in my office, just like Stefano did.
So we share responsibilities among ourselves, which is, I think, very important to understand. This is no doubt an interdisciplinary treatment, and the whole team needs to be involved already at this point, right?
Yes, this is such a case.
Yeah. Well, Simone, I would like to ask you, what is the prognosis of those 3 teeth in your opinion, and how would you treat those that might stay functioning in her mouth?
Your mic is not on.
No.
Yeah, sorry. First of all, thank you. First of all, I would say making a treatment plan is the most exciting and the most complicated thing that we can do. This is why we're here. And as we don't know anything about how Stefano carried out the case, it's very interesting for me. Seeing the teeth, I mean, you already spoiled it. They look pretty much hopeless. And what I am worried about is the 1.1 that has been, that is ankylotic because of whatever happened to the tooth itself. I would say a few considerations. First of all, 16-year-old. So I mean, whatever is at stake increases. That's number one. Number two, we might even think using orthodontics to do a temporary treatment plan or a midterm treatment plan before the definitive treatment plan, because that could also be an option. And in general, Nitsan, as you perfectly know, the same tooth in two different patients can be treated in two different ways, and the same let's say, even in the same patient in a different age, you treat it in a different way. And lastly, the same tooth in the same patient treated by two different operators can be totally different. I mean, from my point of view here, Stefano very clearly explained what it is. The 1.2 is hopeless, absolutely. It can only be used, I don't know, for temporary, but Isabella will not be very happy with it because the periodontal prognosis will be very bad. The 1.1, what worries me is the external resorption, and the 2.1 has very little structure. And in the long term, it could be used for a midterm, not for a long-term prognosis.
And
I don't know if I answered your question.
well, what would you think if you could change the root to crown ratio by, let's say, orthodontic combined with some perio? Is this type of root suitable for you to carry a crown?
Yes, because as you can see, well, I have only seen a couple of shots from the CBCT. The endo requires a CBCT here. So Stefano knows better and can correct me if I'm wrong. Looking at the X-ray, the trauma happened when she was 14, if I understand it well.
Correct.
So of course the pulp was really big. So we are at the limit of seeing here frontally. Let's say I see 1/3 of the root as garapercha, but still, I think that could be absolutely the case. And I see the 2.1 as probably the one that can be saved more than the others.
What is the problem if we maintain number 11 or 1.1, as you call it, and meanwhile try to keep it, although we know that it is ankylosed? What might happen? What are the risks that we bear?
With an external resorption starts, Nitsan, you never know how it's gonna play out, and it might be very quick. But if Isabella is playing something over here and we're doing a flap, I would be very curious to try and
Oh,
have a look at
no.
that. Say again?
I said, oh, no.
No, I'm putting the responsibility on you. They ask me, and I
Yes.
say, well, I need the periodontist here.
But
But I mean,
we need to remember, I mean, we all have some, I would say, experience of some years behind us, and we all know that there are some situations when we see external resorptions that are actually huge, and
Yeah.
the teeth are still functioning for 20, 30, 40 years.
I would be curious, Nitsan, to see what was the situation 6 months ago, for instance, to see how
Okay.
the progression of it would be.
Yeah, okay, that's important point.
The other point is orthodontic, because the tooth number 11 is in a different position from tooth 21. So that's another, but I think Kristen knows better than me here. But even the prosthodontist, when you have, a tooth that is quite a lot in a different position, can be extremely complicated, especially for Isabella when you raise a flap over there. Mamma mia, that's going to be, you never know what's going to happen. So very challenging. I would be curious to share my opinion with you and see if there is any way, because 16-year-old, I don't know, you know better, Nitsan. Is it a little bit early for an implant treatment? So what do you think?
We will talk about it in few minutes, but Per, you're looking now at the remaining tooth structure of the lateral incisor and the central incisor. And as a prosthodontist, what are your concerns if you are going, let's say that number 12 was not cracked, and you need to decide whether you're going to restore it. Number 21, as far as we know, is still solid, the root is solid. You see the remaining two structure, what would you do?
But I can say that the biggest problem with the 1-2 is that you have so little tooth structure left, so that whatever you do, you will keep, you might build a crown on that one, maybe. But the problem is that what about the marginal condition after crowning that one? Can you keep something with good marginal health with with actually a root with so little tooth structure left? I think that would be a challenge. You can always find a way to place a crown and to keep the crown, but I'm afraid that you will have so much reconstruction materials so deep down, so you will have problem keeping the modular in good condition, I would say.
Unless you are able to try and extrude
Yeah.
the root through the gingiva, through the periodontium.
Yeah, and that I think that is an option.
And what about the central incisor? Do you still believe in ferrule?
Well, you mean ferrule to get retention or no?
Yeah, to get retention or to get seal?
Are we talking about 1-1 now?
21.
21. Well, yes, but I think you have the same concerns as with the 1-2 if you didn't have a crack in that one. You need probably to extrude it. And if you look at the picture, if you look at the X-ray, you have actually some structure that you can place a ferrule in if you are a good clinician make a nice preparation, but you should know that you're very deep down, and it is a challenge to keep the marginal conditions healthy.
What do you think is more important, to have 2 millimeters of ferrule of solid tooth structure, or to be able maybe to have an adhesive restoration bonded to the tooth structure?
In this
Do
case,
you think
yeah.
that the adhesive materials that we are able to use today make any difference in this concept of having a ferrule?
In this case, I would say ferrule, because if you have enamel, that's one thing, but we don't have any enamel in this case, and that means that we need to rely on bonding to dentin, and I would say that in that case, I prefer to rely on the ferrule.
Okay, and is there any difference between the finish configurations if you would have chosen here having horizontal preparation like a chamfer, or going more vertically like a feather edge?
Well, the problem is that if you use a feather edge, whatever you do, you get into problems. Because if you use a feather edge, you need to over-contour the crown. And even though I know that in some parts of Europe, it's advocated to use vertiprep and other things, but I'm not into that, because you will get an over-contour crown, and as we know, that's an iatrogenic way to create problems. On the other hand, if you make a traditional preparation, when you have as little tooth structure as you have in this case, you end up with removing a lot of tissue that you need. So it is a tricky case, I would say. And in that respect, I would maybe advocate to, if possible, if we're talking about 1-2 and 2-1, to, if possible, to extrude them if now we play with the thought that the vertical crack in 1-2 wasn't there.
Mm-hmm. Isabella,
Yeah.
She's
what?
not gonna be, sorry, Nitsan, she's not gonna be happy of us extruding the teeth because there's already a problem with the gums. You're gonna worsen it when you extrude it.
So, as Simone just mentioned, let's say that Christine extrudes the teeth very slowly together with the soft tissue, and then you have to crown lengthen and expose some solid tooth structure. What would be your approach in this case? Let's talk only about the central incisor.
So, well, first of all, you want me only to focus on the 11 and the 21? Can I speak of the others as well?
Can speak on whatever you feel like, my dear.
Now, we have a 16-year-old. Her chief complaint is aesthetics. Now, let's put it, first of all, her desire. She's been like this for 2 years. She's extremely young, so implants are completely out of the question for the time being. So, I would already, when we mentioned implants, dental implants to me, in a case like this, is a maybe 2.0 plan when she will be way older. So for the time being, we have a lot of other options where we can bring her to a mature age. Having said this, tooth by tooth, I can see from the radiograph, from the periapical radiograph, she has a very solid periodontium, which is obviously in our favor. She clearly has a bone loss on the buccal portion of the 12 due to the crack line.
Do we have a CBCT slice, Stefano, that you
Yes,
can
I
post
think
on?
we'll look for it.
One moment, Isabella.
Yep.
Okay.
Yep. So if we focus on tooth 12, it is clear and evident that if we leave the tooth, the remnant of the fractured root in place, we may end up with a larger bone loss due to the fracture. So perhaps the only tooth or root that I would think of extracting at this early stage would be exactly this one. However, when we extract this tooth, we perfectly know from all the studies dating back from the Araujo studies that we would have a collapse of the ridge. And because we want to delay as much as possible, and I'm talking about she's 16, at least 10 years, why not 15 years from today, I would envision that the extraction of this root and the preservation of the alveolar bone in the same time in a completely flapless, obviously, criteria with a connective tissue graft, this would give her the enhancement of the buccal portion and the volume to allocate then to be able to support a resin bonded bridge. But going back to the other teeth, because obviously this is in line with the others, what I see is, yes, we have root resorption on the 11. I believe that root resorption can be kept for a long time. We do not know as Simone was mentioning correctly, we don't know whether this is going to be a slow process or a fast process. I've been treating cases with root resorption that with teeth that have been in the mouth for almost 20 years now, which means that this would bring us to the age of a plan B or 2.0 for this patient. So I would not touch the 11. And what I see
Wait,
is,
Isabella, one moment.
yeah,
Okay, when we talk from the point of view of the resorption, I cannot but agree with you. We've been treating teeth with root resorption that might have lasted 20, 30, 40 years even. And we have
yeah,
several cases like that. The problem is always when the bomb explodes. And
yeah.
sometimes you are not ready for it. So you need to take into consideration that once this happens and the crown breaks or something like that, you need to give an immediate solution. But look at the bone around number 11. Look at the CBCT. Do you see any alveolar or any labial plate of this tooth?
It doesn't appear so.
And you would still prefer to leave it?
I would still prefer to leave it, Nitsan. For the time being, I would still prefer to leave it and treat it, because it allows me then to work on the lateral, on the 22, because we mentioned about orthodontic extrusion. Orthodontic extrusion, to me, when we have parabolas, gingival parabolas that are too coronal, it's the opposite. We should work on crown lengthening to reestablish the parabolas, to give her an aesthetic which she's looking for. Because if we go and look at the picture, Stefano, of this smile, or the frontal picture, we see that the gingival parabolas are completely wrong.
Yes.
There are absolutely no proportions. So the 1121 clearly, we need to create a mock-up, a smile design, and we need to understand what are the proportions to maintain. But what I see here is if we extrude, then why are we extruding? To get the ferrula, to be able to restore. But what if we go on the opposite side and we actually do a crown lengthening to be able to find this? I don't know. I'm sharing this with everybody. So
What is the reason that you see this overgrowth of tissue on 21, which compared to the other incisor looks to be, the affected incisor look to be in the best situation, and still you see this overgrowth of gingiva on top of the cervical component?
Well, we should have seen it before the accident, and it could be twofold. It could be passive eruption in general, but I don't think so. It could even be the fact that she had this fractured root portion, and the gingival tissues simply grew over it from that point of view. But I don't see any other reason why she would have this discrepancy, other than the fact that she doesn't have a cemento-enamel junction anymore.
So from this starting point, just making crown lengthening might solve the ferrule problem without even ortho extrusion.
Yes, in my perspective, yes. And it would give her the possibility to gain the confidence in her smile, and by being very conservative, ultimately.
So what you suggest is actually remove number 1, 2, preserve the ridge as we should, and then fill up the gap with a pontic with an adhesive wing on 11 or 13, whatever, right? Am I correct?
Correct.
Okay, so I would like to ask Vince, let's say that we are going this direction, and you need to try and produce the most aesthetic and functional restoration when number 1, 2, the lateral incisor is out of the mouth, and you need to maybe crown number 21. What material would you choose in this situation? And then I will ask you some further questions for other options.
Okay. Thank you very much, Nitzan. And allow me just this little note here. It's really a pleasure to listen to all of you in your different specialities discussing this very, very comprehensive case. So there is a huge learning curve, as always, to everything. And it's a true pleasure to just listen to a discussion and conversation like this. Beyond and coming to your question, Nitzan, to me, the resin bonded bridge that Isabella suggested is also my number one go-to option for this patient. When I saw the case, this is what I had in the back of my mind as a number one option. I would rather try to anchor it in the canine, as it allows us for a much more natural appearance on the contact line towards the other central 1 or 11. And obviously, when it comes to this type of restorations, a resin bonded bridge in the upper jaw, usually there is not enough restorative space towards the palate. We would have to see the bite, but usually the only material of choice is zirconia, so oxide ceramic. As for lithium disilicate, you would use too much space. Having said this,
Wait,
you know,
let's just make it a little bit easier for the audience. When you talk about the limitations of a resin bonded bridge with a single wing, when you talk about zirconia, you're talking about thickness of the wing and about the size of the connector. What would be the minimal numbers for this?
yes, I mean, if you go to the books, you will find like 2 by 3 millimeters, so 3 millimeters in height for the connectors and 2 in width. That is basically for the tetragonal zirconia, the more opaque style of zirconia. Today we have mixtures, we have graded zirconia, so you cannot just simplify it to that extent. But usually, especially with today's kind of morphology and design of the restoration, we will be able to have these thicknesses. And when it comes to the backing, we advise not to go below 0.8 millimeters. Obviously, in the palatal side of the canine, there will be enamel to bond to, so that should be rather easy then.
So at this point, if we are going towards this solution, we need to ask Christine to move the teeth in such a way that she leaves at least, I would say, 1 millimeter of space between the abutment, if it is now the canine, and the opposing dentition, right?
I guess
Correct.
it would be difficult to do this with the canines in this position.
So if you're going to correct the class 2, what would you do here?
You asking me?
Yes, of course.
Yeah.
We know nothing about moving teeth.
I would correct it, like I said, with a carrier appliance.
Okay. And then you could have provide the space for the palatal wing on the canine?
I guess so, yeah.
Okay. So here we have a good solution for 2 problems, right? Then, Vince, what about the material that you would choose for the crown on 21 if we leave the tooth?
Yes, I mean, for me, that is very clean and clear because you don't want to mix materials so close to each other. So first of all, as a reference teeth, the remaining teeth, they're rather opaque, which basically gives you the best fundament working with zirconia. And then you have the resin bonded bridge also being based out of zirconia as a restorative material. So that simplifies everything. So my suggestion would be to do the resin bonded bridge made out of zirconia as well as the single crown with the buccal veneering to enhance the aesthetic.
And if the prosthodontist choose to go with vertical preparation, like the BOPT, that is very popular in Italy and in some other countries, we know that over-contouring the restorations proximally do not cause any problem to the tissue. On the other hand, we know that if you over-contour the restoration labially, not in an anatomical way, then you might find yourself in some violation of the tissue. So for you as a restorative technician, is the material important when you relate to the type of finish configuration, whether it is vertical or has also a horizontal component?
Yes, it absolutely is, because you see the big challenge, as you very well know, is that if you have, for example, a lithium disilicate or reinforced glass ceramic, and you have it to some extent thinned out to an extreme, which sometimes occurs in a vertical prep type of preparation, then you will end up with certain movements in the crown during the firing process. And that is something that is really disturbing, and it gives you imprecision with the final restoration. It is very challenging, and many times you will end up with fractures around this crucial finish line. So for me, doing this type of restoration zirconia is again the material of choice, at least the way that I work on a day-to-day basis. Because on top of that, it not only allows me to really create it in a very thin and reproducible finish line, but also I'm able to polish it to a very high degree, and that, you know, just guarantees like a perfect biological integration.
Per, did we forget completely gold alloy-based crowns? I mean, we have to not even consider this type of restoration.
Oh, we didn't. We can actually use gold alloys, but for several reasons we don't use it anymore, and that is one of the big reasons is actually the cost. But when it comes to a case like this, it wouldn't be an option whatsoever, because you don't want to put and go an alloy like that so close, so deep down below the soft tissue level. So I wouldn't say that would be an option.
You wouldn't place it because of what?
Because of the metal. That
But
you don't
if you
you
have
don't want to place the metal so deep down close to the, especially when you, if we consider to make some crown lengthening or any other technique to get a possible ferrule, then you don't want to place well, I do agree that if you want to place a material down there, which should be zirconium dioxide. But on the other hand, I don't agree that a vertiprep is a solution that is biologically acceptable. For me, that isn't biologically acceptable.
Yeah, but we have to look at the data that has been published in the last 8 years about BOPT or vertiprep or combinations. And if we believe those people that published it, and we know some of them personally as reliable people, and some of us have also their own experience, in certain situations with the right technician, I believe that even vertiprep can be a nice treatment modality. But as I say, in certain situations, the problem is always to understand how to prepare the tooth, and more important, I believe, how to build up the contour of the restoration. And this is tricky many times. But let's say now that we have a crown on top of 21, and we have a pontic that is connected to a palatal wing that is bonded to number 13. And the patient is 16 years old, Christine. She keeps on growing together with her premaxilla and her jaws. How would you maintain the situation in terms of splint or removable appliance or both?
Are you talking about now that we have a class 1 situation on both sides?
Yes, you have class 1, you move the teeth. There is now a restorative option that we just discussed, but we know that her jaws keep on moving, and you don't want it to happen. So you need to have kind of retention. What type of retention would you choose?
I would probably just use a removable appliance in this case, because it's we have porcelain or whatever we have there. But a 16-year-old girl has probably finished most of her growth, maybe not the vertical growth, but at 16 for a girl, we would not expect too much growth to be left.
So
And
why
in this
don't we?
area,
But Christine, as Isabella mentioned, there is a reason that we don't place implants, single implants in such situations. For sure, not at her age, and even not in older age. And the reason is because of the vertical growth of the premaxilla that we see very frequently. And
yeah,
then
but you can't retain that. This is probably the only growth that we have to be worried about, and this is the only growth that is probably stopping us from placing implants in such a young individual. I wouldn't worry about the sagittal growth. I think just a removable retainer would be enough. Just a normal bite plate, you know. But this is all. This is just there are so many questions, and maybe this emphasizes how important it is when we have young individuals, and not treating them to a class 1 when they're younger. You can see here, this maybe wasn't a problem until she had this accident. We have the deep bite because of her distal occlusion, and we have difficulties in treating this patient because he's not doesn't have a neutral occlusion. So maybe we can learn from this that this individual, if she would not have had this accident, she would probably have been functioning all her life without any problems. But because she had this accident, it's all more complicated because of her unilateral distal occlusion.
When you look at the premolars and canines, would you suspect delayed passive eruption? When you look at the level of the tissue and wherever is the CJ?
Well, when we were seeing her smile, she has a gummy smile, but when you look at her smile, it is, because I was thinking about tooth 1-1 and the gingival display, and because I thought it was a bit high up. Yeah, but when you look at tooth 2-2 and 2-3, maybe she has been brushing them a bit, but I think, you know, this is quite the same level, because we usually want to have the central incisors and the canines with the same gingival display.
And what about 1-3 and 1-4 and 1-5?
Yeah, and there you see the lip. She lifts more on the right side than on the left side.
Yeah.
So this is also getting things more complicated.
I know.
I think if the lip would be a little bit less active on the right side and it would be more symmetrical, this would probably not be as much, you couldn't see us as clearly. So I think everything on this case is difficult.
This is why she was referred to Stefano. Otherwise, they
Yeah.
would refer her to me, I think.
Yeah, but you were talking about the extruding those teeth. I didn't talk about that because I thought in this case you don't want to extrude those teeth. It will only get things worse. But we also have to think about if tooth 1-1 is ankylosed, which yeah, that is like an implant.
Okay, now I have a question to all of you. Let's say that we have a crown on tooth 2-1, we have a pontic on 1-2, and 1-1 is meanwhile functioning, and something it breaks, or there is a periodontal abscess that cannot be treated anymore, and you have to remove tooth 1-1, and the patient is still at her adolescence. What then? Isabella.
Can you repeat on the adjacent teeth what she has?
She has a pontic on 12 and a crown on 21.
A pontic of 12 and a crown on 21, and she loses the 11.
Yeah.
Well, so as we said, we have to work on a prosthetic option rather than positioning the implant. So in that case, perhaps, but I don't know if the longer span, because then the pontic on 12, the Maryland, the resin bonded bridge on 12. I don't know, because if you think about it, I'm trying to figure out a solution from a prosthetic point of view, which I'm not, that could manage the three teeth, basically.
Yeah, the two missing teeth, the central.
The two missing, the central and the two missing teeth.
Yeah.
The other option.
Okay, okay, you're periodontist. We don't want to make it hard for you right now.
And I like the challenge.
We'll challenge you further. Wait, down the road, Simone. You're also a restorative dentist. What would you do?
Well, if, in case you lose the 21 or in general?
Both of them. You lose 21, you already lost 12. No, you lose 11, sorry.
11.
21 is in place.
Well, I think I'm not a prosthetic guy, but anyway, the 11 cannot bear the two teeth. So one option could be to have a Maryland bridge, as Vincent was mentioning before, on the 13, bring in the 12, and the 21, you have a crown on the 11, you use that. But that's again,
No, 11 is out now. Let's say that
11 is out.
yes, 21 is staying there with the crown. 11 is out. 12 has been already removed, and now it is rehabilitated with a pontic that has a wing on 13. So now you have to actually try and fix two missing teeth, one central and one lateral incisor.
On the same side, which is very complicated because the 16, as we are scared of the growth, and Christine knows better than us, we cannot link two parts of the mandible, of the maxilla. So that's the main problem. So you have to split that somehow.
So what would you do?
I would like to be just an endodontic guy tonight and say,
I have a question to the prosthodontics. A cantilever crown off the 21, would that be completely crazy? That is possible? I don't know.
I would say with that route, yes. With the route that you have, making a cantilever, that might be a little bit risky, I would say.
Yeah, but what would you do? Let's say that you don't take this risk and you still need to fill up the space of central and lateral incisor unilaterally.
But you can say that the answer is very easy because the big challenge is actually the patient's age. And you need to buy time. And in the long run, I think implant is something that you need to go for. But you can't do that now. You can't do that in quite many years. So what can we do? We have the 1-3. 1-3 is without any, there isn't a single filling on it, if I see it correctly.
Yes.
Yeah.
Means that is something that you don't want to do anything with that one. And then you had on the other side, you have the 2-1. And the 2-1 is, well, you have a poor root, you have maybe a poor crown. You can't do that much about that one. So what can you do? Well, you need to find some kind of appliance so that you can buy time. And you don't have that many options, actually. So the tricky question leaves you in a very easy answer, actually, that you might do something just to save time, and that, or to buy yourself more time, and that might be either a removable appliance that you don't want to give a patient for a long time, and then of course there are possibly some other options where you bond or whatever. But now you have a crown on the 2-1, so you don't have that many options, actually.
Yeah, well,
And I
we will talk later on. Maybe we will talk about the philosophy of leaving a virgin tooth as is, and maybe taking major risks because of this philosophy, instead of maybe sometimes preparing very gently the tooth for a full coverage and working very, very precisely with a great technician. What's the big deal? It's not that every preparation leads to root canal treatment, to fracture, to removal, and to implant, as many dentists used to tell us in the past. But let's leave it now. I would like, if we can see several options that we were discussing here, and if we could ask the participants vote for each one of those options. Is it possible, Fabian? Stefano?
Yeah, here we have the first question that you guys should answer. I mean, everybody, participants as well. So provided the 21 is maintainable from a structural point of view, which therapy would you recommend? surgical crown lengthening to bring it to the same level as 11, or tooth intrusion if orthodontics is contemplated for other reasons. So
And
everybody,
what do we need to do? We need to just
click.
mark,
You need to
click.
click,
Okay.
yeah, but not us. You know,
You
the
should not do
panel
it.
cannot do that. The participants should be able to do that, and then we will see.
Yes, they are, and they're already doing it.
Okay.
So I will let it there for a minute and then show the results.
Okay.
Okay, and then we will pass to the next question, right?
Which is a tough one. We don't have a lot of time left. A good discussion, Nixon. Good discussion.
Fabian,
Do
it.
you want to see the results
Yes,
Yeah.
please.
now, or do you want to have first
Now.
other questions?
Now, if it's possible.
Yeah, sure. Just maybe 10 seconds, so the rest is able to.
Nitsan, I may have an idea to your question about how to replace the two missing teeth.
Great. So after we see the second question, you come
Yeah.
up with your idea.
Yeah,
Great.
but it's crazy, but it could be.
Fabian?
Yep.
Okay. Here we are. So
Mhm.
most people, and Nixon, most people would go for crown lengthening.
Yeah, as Isabella was mentioning at the beginning.
Maybe it's wrong, Stefan.
We will see.
Well, what I'm concerned of about the crown lengthening is the position of the 1-1, which is completely
Yeah.
without any bone on the buccal plate, which is why I would I would really love to do the crown lengthening, but I wouldn't like to be the periodontist doing the crown lengthening, honestly.
Well,
Let's go to the second question, Stefano, because we
Yeah.
still want to see what you did and then to discuss it as well.
And we don't have a lot of time. So go ahead, Fabian, number 2.
Yep,
So which
there it is.
treatment option would you suggest for the replacing of the missing or compromised teeth? We said for sure 12, possibly 11. So we extract, number 1 is, the first option is extraction of both 12 and 11, crown lengthening of 21, and then a 6-unit fixed dental prosthesis from 13 to 23. Second option is
With two
extraction
Pontics.
with two Pontics, with 12 and 11 as Pontic.
Yeah, okay.
And so you have 1 abutment on the right side, 13, and 3 abutments on the left side, 21, 22, and 23.
Okay.
Extraction of 12, 11, and 21. Placement of implants in 12 and 21, and then a 3-unit fixed dental prosthesis without touching the natural teeth. Number 3, extraction of 12 and 11, implant placement in 12 and 11, and then crown lengthening of 21, and then single crowns. Implants 12 and 11, and natural tooth 21.
Wait, can you repeat it? Wait. Can you repeat this option as well?
This option is you extract both hopeless teeth, 12 and 11, you place 2 implants in the same sites, and you do at the same time the crown lengthening of 21, and then you can manufacture 3 single crowns. 12 and 11 are implants, they're adjacent implants, and 21 is a natural tooth.
Okay, and the last one?
Then you have 2 more, extraction of 12 and 11, implant placement only in 11, and you do crown lengthening on 21. So now you have a cantilever fixed dental prosthesis of 11 with 12 as a Pontic, and a single crown on 21. And finally, extraction of those 2 teeth, 12 and 11, crown lengthening of 21, of course, and then orthodontics, not only to correct the class 2 malocclusion on the right side, but to actually redistribute space. And then once you have redistributed space, then implant placement, when age will be the right age, in the edentulous spaces are generated by this redistribution.
Can we vote on one of those options, Fabian?
Yeah, sure. I will
Okay,
show you
A lot of options, as you can see, a lot of options.
But you can vote only for one.
Yeah.
Okay.
Yeah, only for one. Sorry. It's not a multiple.
No.
Just
You need
for
to
one.
choose one. So, you know, we're giving number 11 as a eventually hopeless tooth, maybe not at the very beginning, but, you know, I assume that with this amount of tooth resorption, of root resorption, eventually this tooth is going to be lost. And so
Okay.
we need to change to see that.
So here are the results.
Okay.
What are the results? The
Needs
majority
healing.
go.
So a
we see
lot of
that,
people will do the 6-unit bridge in the front, 26%.
yes, that's right. About, you see that 1/3 would go for 6-unit bridge, and 1/3 would go for the last option, combining ortho, crown lengthening of 21, and extraction of those two teeth. And then we have the other distribution of the other options that is about 10 to 15%, which is very interesting, by the way. Isabella, what was your crazy idea?
A crazy idea to replace the 11 in case it has to be extracted for God knows what reason, because we don't, whatever, the root resorption bursts out or whatever. A mini TAD, a mini screw on the palate with a provisional, with a crown, basically.
Yeah, this is a nice idea. You can have it.
This would be very conservative and it doesn't affect any growth or anything. And
Yeah,
it resolves the issue of two adjacent teeth.
yeah, I agree with you, but unfortunately, we didn't give it as an option. But
Yeah.
this might be a good immediate solution if this happens. I agree. Stefano, we have several questions from the audience. Most of them,
Stefan's smiling.
but
Yeah, but we're curious now, Stefano.
Now
Yes.
we're curious, huh?
yeah, well, we have questions from the audience, but I believe that most of the questions were already answered throughout the discussion. Let's see what you chose to do. And then if we will have some time, we will try to hit you with your choice.
Okay, so here we go. Here's what we ended up doing. So first of all, let me give credit to the team who treated this patient. So Matteo Capelli, who's my partner in the office, did all the surgical and eventually implant therapies. Keep in mind, this patient came to us in 2015, so that's 10 years ago. David DeFranco, the orthodontic therapy, and Luca Vailati, the dental technician who actually made the manufactured the prosthetic work. So as we mentioned before, what are the biggest challenges in this case? Well, we have a tooth that is lost because of the fracture, number 12. We have 11 who is ankylosed and evidence of root resorption, which who knows how long it's going to take to lose it, but eventually I'm pretty sure that we will lose it. And 21 is definitely structurally compromised, but at the same time, the gingival line is very coronal. So if, you know, now 11 is lost, you already have a 2-tooth span in the front in a high smile person. If eventually also the 21 is lost, then triple tooth edentulous space, quite a challenge. We have an asymmetrical gingival scallop, but that is not preoccupying. We know, as Isabella said, we can actually manage that and solve that. Of course, the extraction of 11 may bring more bone loss and therefore an apical migration of the gingival complex. So this is something to also keep in mind if this tooth is going to be removed. But at the same time, this tooth is really far out to the buccal. It is an issue and a challenge for me. So 12 was definitely, without any question, fractured and therefore needed to be removed. Main issues, young patient, high smile line, multiple adjacent anterior teeth to be lost, this class 2 relationship on the right side, and a large anterior overjet. These are all issues which I look at and ask myself, oh my goodness, what am I going to do here? And she's only 16. So here's what we ended up, you know, doing and discussing with David when we sat down to look at this patient together. So a flat profile suggests to us, do not extract, certainly not the premolars, not the back teeth. The incisor inclination for the upper does suggest that we need to torque or procline this upper teeth. There is some very little crowding, so no extractions here. The idea is to go for a class 1 relationship also on the right side, and this would allow the correction of the midlines, and this would make it easier for me as a prosthodontist then to create the proper guidance. Now, when we contemplate orthodontics, we always need to sit down with our orthodontists and the entire team and define what are the general aims of the orthodontic treatment. So certainly in a patient like this, we would say level and align the dental arches, expand the maxillary arch in order to correct the posterior cross bites, reduce the amount of overbite and overjet, obtain the neutral occlusion on the right side while maintaining the neutral occlusion on the left side, and at the same time try to reduce or even eliminate the midline discrepancies. So these are the general aims that should, in our opinion, should be set for ourselves if the patient goes for orthodontics. Now, if we look at orthodontic options, the first option that was considered was to distalize the upper right quadrant while mesializing the lower right quadrant to obtain this class 1 occlusion, and then replace the lost teeth with prosthesis, but we're talking about 2 adjacent teeth, missing teeth. So this, of course, is quite a challenge because it's, first of all, it's a very difficult type of movement to carry out, as also Kristen suggested. In our opinion, it would take more than 12 months for sure, possibly closer to 2 years at least. And you need to have appliances that really have a good skeletal anchorage in order to rely less on the cooperation of the patient. But the big issue from my standpoint, then I have 12 and 11 missing next to each other in this size mild patient. So another option B, would be to instead mesialize the upper right quadrant. I mean, bring the canine forward into the lateral incisor position and mesialize the lower right quadrant as well to obtain this class 1 occlusion. And this would produce at the end only a single edentulous space, and which is definitely more predictable to restore with eventually an implant, or for the time being with a single wing prosthesis, fixed dental prosthesis. Again, this mesialization is not easy. It's difficult and time consuming, and again, it requires skeletal anchorage. Now, there is an option C, and the option C, as you can see here, is actually to bring forward the canine, the right canine, to the lateral incisor position, and the first premolar to then act as a canine, while at the same time distalizing the other 3 posterior teeth to open up a space for another premolar in the number 14 position. So this is actually something that would help us go into the right direction, because you're actually maintaining only one single edental space in the front for that of number 11, and you create a second single span in the back, in the premolar area. So, orthodontics indeed is something that we do take into account and consider in so many situations when we see our patients. In this case, for Carolina, it is definitely a very valid option because she's young. And there is no question that it's the secret in obtaining a best possible outcome with the least invasiveness. We would definitely be able to reach the goal of improving aesthetics with the improvement of the midline alignment, the canine guidance on the right side, and at the same time, create a proper symmetry, gingival symmetry in the anterior quadrant, which is so visible to everybody. Now, option C, therefore, was our #1 choice because the prosthetic treatment is more conservative. And I eliminate the complexity of having a double edentulous span right in the front. Of course, the treatment time, David told me from day one, is going to be long, at least 2 years, probably close to 3 years. And when you do such a treatment with bodily movement in the horizontal direction, the potential for root resorption is there. There is no question about it. Also, it gets to be more time, more treatment time, more expense for the patient. And there are many aesthetic issues you need to deal with during the treatment. And for a young patient like this, I know from the start it's going to be difficult for her to accept. No question about it. So here we go. This is what we propose, and this is the option that was accepted by the patient. So immediately we removed the broken tooth, number 12, and I did a temporary cantilever of the canine because there was enough space on the palatal of the canine to put resin. And at the same time, we did the root canal retreatment of 21, a direct reconstruction with a fiberglass post and a composite resin core. And then I placed a new provisional with the margins inside the sulcus, deep sulcus that this patient had. So, here she started from there. And in the meantime, David started setting up the case for ortho. And initially, our idea was actually to move forward everything. But then eventually we understood that there was a better way to do things. And you will see at one point we changed direction in the sense that what we did, we started, and you see it from this view, you can see it better. We are moving forward the canine to some extent while correcting the crossbite in the back. And then eventually we started moving back 17, 16, and 15 to open up a space behind the first premolar. So now we are bringing the canine into the lateral position and the first premolar into the canine position. And you see how long it took. I mean, we are talking about 3.5 years, okay? Of course, it's easy to just tip the crowns. Here, there was a bodily movement because the idea is that eventually to place implants both in the front and in the first premolar area. And, this is a situation at the end of a little over 2 years. The central incisor in number 11 was clear to us that due to the very wide amount of root resorption, it was a tooth that we could not rely on. But at the same time, being ankylosed is a great anchorage. As Kristen said, it's almost as if it is an implant that provides great anchorage for the orthodontic movement. So at this point, we did use it all the way to when we could use it. And you see, to the point we brought the canine into the lateral position. Again, this canine is not particularly big, so I knew I could kind of do some ameloplasty to make it resemble more a lateral incisor. And once we got there, then we removed this ankylosed tooth, and you can see the big area of root resorption all along the buccal surface. So it was not easy to remove it initially, but eventually came out. And here it's you can see exactly what the issue was with that root. Now, I would like to point out one mistake we made. When we removed tooth number 12, we still had not discussed and talked about the possibility of moving 13 in its position. So when Matteo removed the root, he actually did what he normally does to try to preserve the alveolus, the volume of the alveolus of the ridge as much as possible. And therefore, he positioned inside the alveolus some non-resorbable material to actually fill in this space and to then maintain this volume. Now, this proved to be a real issue once we decided to move 13 in position of 12. And what you can see here is basically the movement kind of pushed out to the buckle all the non-resorbable material which was placed into the socket, and also slowed down the movement itself. So it became an obstacle to the mesial movement of number 13. So this is actually, one thing we have learned from this case. Really think very well your treatment plan before doing such a thing. Otherwise, it's gonna, turn against you. And this kind of issue has already been pointed out into the literature. I will not, go into it very deeply. So this is a situation at the end of the orthodontic treatment. I did once we removed number 11 and created a metal-supported provisional of 21 with 11 as a cantilever. And this is the outcome of the orthodontic analysis post-treatment. Again, the cephalometrics will show you the changes between the before and after. So we're talking almost 4 years later. And you can see here the position of the central incisors, which was actually more inside than the start. There was not, huge changes and very little growth in this patient in these 4 years, as Kristen rightly pointed out, and she was 16 when we started, so there was not a huge further growth. And you can see here again the tracings that show you the differences. Now at this point she's 20. So here is the patient with a provisional of number 21. And in the back, once we obtained the proper space for the premolar, we actually went ahead and did a resin-bonded long-term provisional. It's a metal framework with a composite resin tooth, because we know that we are going to go ahead with an implant in the next couple of years. We are less concerned about placing implants in the back than we are in the front in a young female. And but in the meantime, she was happy and satisfied with this temporary measure. And here in this slide, I kind of summarize all the different steps that occurred during the therapy, just to show you the changes. And when we went ahead with the crown lengthening of number 21 and the placement of this cantilever temporary bridge off of it, and the healing over time. But it's very interesting to look also from the radiographic standpoint of what happened during this time. And what happened is that there has been a root resorption of number 21, even though 21 was not moved horizontally, was not extruded, was not intruded, but it was, part of the, anchorage in the orthodontic appliance. And this you can see even better in this slide. You can see the amount of root resorption that has occurred at 21. So, this is quite a surprise for us. It was quite a surprise. I was not expecting, because we did not move this tooth. So this is another challenge, because at this point, we are saying, okay, the possibility that this resorption is going to go further in a way forces us to go ahead and place an implant in number 11 at this point to anticipate the time in which 21 is going to be lost. So she has been in a provisional restoration for now, a number of years. So you can see, how we accompanied the patient over the entire path. So the orthodontic treatment definitely was a long treatment, longer than we initially expected, but all goals that were set for ourselves were fully reached. This orthodontic treatment was due to two reasons. First of all, the late decision in mesializing number 13, and also the movement of the canine into an area which had non-resorbable material. Now, because of what I showed you, we are convinced that the long-term prognosis of 21 is not good. And so we need to, decide to move on with implant placement. By now, she's 25. So we felt that it was, enough for us to be able to place in safety an additional implant in this area, in number 11. Anticipating issues with 21. And, we have very clearly in mind all the literature that tells us that we really need to be careful in placing implants in adolescents. The biggest issue that can occur is the fact that due to continuous vertical growth, you're going to have infraocclusion of the crown supported by the implant with respect to the rest of the arch or maxilla. This has been very well spelled out in this great article that was written by Roberto Cocchetto and published on the International Journal of Aesthetic Dentistry a few years ago. So for a review of this topic, I would recommend you to go and look at it. And here we are. This happened about 3 years ago. We placed a single implant in the premolar area while maintaining the cantilever provisional in 1121. And we eventually made a zirconia supported single crown screw retained to the implant. So, we're still looking after her. As I told you, we are moving on with the implant now in number 11. We are keeping an eye on 21, but for the time being, there is no plan to remove 21. Having an implant in number 11 gives us the safety margin to act swiftly if 21 is going to fail. So Nitzan, this is a treatment that we carried out. You have your microphone muted.
Yes, thank you very much, Stefano. I think that you surprised us all with your creativity. I think that if something happens to the central incisor, you can always start with single retainer cantilever adhesive bridge, one on the right canine with a pontic, the canine that is now lateral, but it is still a bulbous and large root tooth that you can definitely support cantilever for number 11, and then you can have 21 as a pontic with a wing that extends to 22 and 23. So there are ways, and as Isabella mentioned before, and some others, Otto and some others in the audience, you can always place palatal implant that will, yeah. Okay, so this can be managed. I would like just to ask our panel of experts one question. What do you think was the reason for the root resorption of 21? And I would start with Christine.
The reason for the root resorption?
Yeah, of 21.
The tooth came out and it was put back in. This
No,
is
no.
Not 21, not 11. 11 was,
yeah, that was 21.
yeah,
Yeah.
21 was not lost and replanted. It was there from day one. It was then,
Yeah.
endodontically and
Yeah.
not moved in any,
Wow.
considerable way.
Wow. Well, this is very individual if we have root resorptions or not. And sometimes I have some cases that I'm not very proud of, and I saw it only after a few months. Severe root resorptions in teeth that I thought I didn't move too much. So that's very individual. We have, of course, a lot of activity of osteoblasts and osteoclasts when we're moving teeth. And that is probably one of the reasons. The orthodontics is probably, even though we don't move the tooth, it affected that root. It's
Yeah.
difficult to say.
I think if I can say, I think not only the orthodontic movement, I saw a case of a very severe resorption of the root, like super very severe, like 3 days ago in the clinic. In this case, I think a role was played by bacteria, Stefano, because even if you did the retreatment, and that was absolutely correct, if there is an infection on the outer portion of the root, that can absolutely play a role in the resorption. And
And
I think you ended up giving the tooth the best prognosis by redoing the endo and putting in the gutta percha was still there. So there was a resorption that was limited by the intervention.
so would you go for an apical surgery to try and clean up the periapical region?
I always try to save teeth, I have to say, but in a case like this, I think there's a moment when you have to stop. I think Stefano knows better what has to be done here, and of course, it also depends on the patient's acceptance of the treatment planning. The tooth in general, I think, has a very bad prognosis in the long term.
Isabella, looking at the situation of the extracted number 11, would you still think today, now, that you would have tried to keep it longer?
No, I must admit. No, I must admit the lesion was very severe. So it's been a great case also to open your eyes, because we're always convinced that, it gives us strength when we have cases that have lasted 20, 30 years. So we think that every root resorption can last like that, but obviously this is not the case. So I think it's a lovely, that picture, Stefano, of the tooth extracted with the root resorption, I think will be kept in the minds of many of us.
Okay.
And Isabella, just a little thing. This happens very often with teeth that had trauma. And I think even on 2.1, the resorption at the apex could also be a part of.
Yes, I was gonna say, but so many years
But
later.
you never know. You don't have a definitive.
Yeah.
Luckily, in medicine, there's no 100%. So.
Well, we know that osteoclasts were somehow driven there suddenly, and the reason for that might be maybe a periapical lesion, contamination, or force during the orthodontic treatment that was not noticeable. And now this is the situation. She's still with these two provisional crowns on the central incisor, right, Stefano?
Yes, she is, but we are going ahead with the implant in number 11 now.
Per, would you place an implant in number 11 and have a cantilever 2-unit bridge?
Per is lost.
No, because your mic is...
Microphone is muted.
Your microphone is not on.
No.
Okay.
Sorry, you say if I would have placed an implant with a cantilever?
Well, if number 21 is going to be removed and you can place an implant at number 11, would you place it and leave it there, or would you go for an immediate placement instead of number 21 and cantilever number 11? Where would you choose to place a
I
single
would,
implant?
if I got the question right, I would have preferred to have 2 implants. And if there was 1 implant and I lose the other one, yes, I might consider to place that one immediately.
Okay, okay. And Vince, if you have now to give us a recommendation towards what type of material and what type of restoration would you choose? Would you choose to have two single implants on the two centrals with obviously shortened single papilla that is not so obvious aesthetically, but it will be, or would you prefer to have one cantilever as a pontic and an adjacent crown on top of the implant?
Yeah, I mean, it's again a good and difficult question. What I really don't like to have is a connection between the central incisors, because it's very, very difficult and demanding to hide this, and the patient has obviously a full smile, so it is gonna end up as a very challenging case. So definitely, as a technician, I would prefer to have two implants. And with this, I would have the chance to create a perfect emergence profile, a separation between the teeth. And I would even, consider, as we have now, a canine in the lateral position. If I have only the chance for one implant, I would still consider the resin bonded bridge as a treatment option to basically support one central and then have the other central supported by an implant. This
So
can
you,
also, lead into other issues, because then you might have a slight disbalance with the papilla tips and so on. But certainly to have this connector area between the two centrals is extremely challenging. And looking back at all my own cases that I have produced, none of them really blows me away.
so Stefano, there might be a recommendation from the panel. If you go for a single implant, go for 21 as an immediate implant placement.
Okay, and just have the single wing adhesive bridge of
Yeah, or cantilever it. You can cantilever it on
Yeah.
top of the implant, whatever.
whatever ways.
This is it's very interesting. If we go back to the original question of the treatment options, and now the audience have to choose after we saw what you did, what would be their decision today, based on what you did or what they thought before or what could have been done?
Fabian, can you put up the question again? So let's see if people vote in a different way with respect to what they did at the beginning.
Remember, the two main options that were selected were either a 6-unit bridge on the canines and two pontics unilateral, or moving orthodontically and have
Yeah, but a third of the people did choose that.
yeah 2/3 of the people went for these two options.
Yeah. Fabian?
Sorry.
Okay. So if we can put it up, and then we are
Poll number 4.
yeah, the poll number 4, which is actually poll number 2. Here it is. So
our audience are invited to select one of those 5 options now. What would you do when you know everything, almost everything?
having seen what is the outcome, orthodontics is really something so powerful. It really can help so much. And we think interdisciplinary all the time. And this is something that I have to give credit to David DeFranco, because of his ability and demonstrating to me, the potentials of orthodontic treatment.
Mm-hmm.
Of course, you need the patient who understands. You have to be able to convince them. But if you are convinced yourself of what you're proposing the patient, you will be able to convince the patient. This is what has been my experience.
I agree.
So it's the
What
same.
are the results?
Yeah. Fabian?
Yeah, the results are coming at 10 seconds.
Okay.
Okay.
Good.
Here they are.
Here we are. So now most people, go that way, but there's still quite a, 40% still would go for the other options, Nitzan.
Yeah, but not for the first one. The first one was a 6-unit bridge.
Yeah,
There
that has been
30%, now it has been declined
yeah.
to minimum, and more than half will go for extraction of those 2 teeth, crown lengthening and orthodontic, to redistribute the space. Maybe not as you did, because we didn't mention exactly how to redistribute the space. But I believe that there was a very interesting thinking process throughout this webinar that made several hundreds of people, or tenth, to maybe rethink and change their minds. And I think that this is the main advantage of such webinars and think tanking. So I'd like to thank you all, my friends. I believe it was a very interesting 2 hours. Thank you, Isabella. Thank you, Christine. Thank you, Jan, as well, Simone, and Per. Thank you so much
And Vincent.
for your time.
It was a lot of fun.
Stefano.
Well, and next webinar is going to be June 4th, with Nissan again as a moderator and Stavros Pelikanos as our presenter. So if you look at this QR code, you can reach the website of ENDE, where all the news are going to be published and updated at all times. And I think we also need to thank Quintessence and Fabian in particular for hosting us in this exercise, and looking forward to more collaboration in the near future with Quintessence Publishing. So thank you, Nitzan, for your great job in moderating this session, and thank you all for the feedback. I really learned a lot, even after all this.
Me too. Thank you very much, Stefano. Thank you, Nick.
everybody.
Thank you so much. It was very interesting.
Thank you very much, and thank you very
Very
much
nice,
for the very
nicely
nice
solved.
pace.
Thank you. Bye-bye.
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 Bye, Nitzan.
Thank you very much. Bye bye.
Bye.
Bye.